want to thank Optic for the kind invitation, and I'd like to speak to you today about our experience in a tertiary practice, anterior segment practice of using this marvel, the Artisan lens in retropupillary fixation, and also some pearls on the IOL power calculation. Just on a personal note, these are my financial disclosures. I've used the Artisan lens, I think my first training was in 1997 by Jan Wurst in Groningen. And I had used it initially as in Europe as a simple solution in combination with penetrating keroplasty instead of suturing a IOL in the sclera. And I'd found it at the time a very convenient solution. Of course, the initial application was over the iris, the same way it was used as a phakic IOL. And this is part of that paper published in Cornea back in 2002, I think, or 2003. Now, as you can imagine, the lens was fixed in front of the iris, so the calculation of the lens included an A constant that's similar to the A constants that we use for anterior chamber intraocular lenses. It's a 114, comma something. So this is an example on how, this is one of our patients from last week that we calculated with LensStar biometry several lenses that we use in our practice and the Artisan lens. So this is the actual length, and here these are the two typical lenses we use for routine cataract surgery, the Acrosoft and the Technice, and you can see they have a different A constant. This is for the Acrosoft, this is for the Technice. And now if we're going to use the Artisan, there's two different parameters. This is for the Artisan used in the anterior chamber over the iris, and this is for the Artisan used retropupillary. So they have a different A constant. The A constant for retropupillary is 116.9, so almost 117, and for anterior iris enclavation, 115. So that's basically the pearl. If you do this manually, it's very easy to do the calculations with the manually. We have the LensStar calculator do that for us. And I'll go on to some clinical examples of its use and how easy it is to use in comparison, of course, to suturing an intraocular lens on the sclera or suturing an intraocular lens on the iris. And of course, you don't need this introduction, so we'll go to the surgery. So this is an anterior chamber, as you can see here, anterior chamber intraocular lens, a Kelman type with the haptics encorching to the angle. So there's a cornea edema, so we have pseudophakic bullous keratopathy and an anterior chamber intraocular lens. So we're going to go in, you can see the marked inflammation that this eye has from all the glaucoma medications, and because of the angle closure. Fortunately, the edema in the cornea is not dramatic, and I prefer in this case because I'm also going to perform a glaucoma shunt to use a scleral tunnel. So I'm using some of my old training in extracapsular surgery to create a long extra tunnel, which does not actually require suturing because it is going to be quite watertight. Remove the anterior chamber intraocular lens. This is the easiest case. Sometimes the haptics are engulfed in the angle and scarred in the angle with synechia, so then it takes a little bit of more of a work. Perhaps a gonioscopy attempt to cut the haptics and then pull them from the other side. So here, as you can see, we're not, there's no vitreous present in the anterior chamber. I'm using viscoelastic, the Artisan lens. I'm going to flip the lens upside down and then go in, first dip the initial haptic under the iris, thus having control and no chance of losing the lens in the posterior chamber. And once that is fixated, switch hands, grab the enclavation needle on my right hand. As you can see here, swift the iris around it, enclave the trailing haptic, and that's it. That's basically it. At the end of this procedure, we're just going to place a amide valve implant, and I'll fast forward that, which is really not relevant to our subject today, but the point I want to make here at the end of the procedure is that the amide valve is placed, the amide valve tube is placed in the anterior chamber, and moving the intraocular lens behind the iris gives us a lot more room and a lot of flexibility. And this patient actually ended up doing extremely well. The bolus keratopathy resolved, and the intraocular pressure was under good control. So a very easy procedure in comparison to suturing the lens on the iris and or the sclera in this eye with that had multiple surgeries. So here we're going to see a combined penetrating keratoplasty and cataract procedure in a patient with Axenfeld's anomaly. Axenfeld's is chromosome 11 irregularity that causes synechiae between a posterior embryotoxin, synechiae between the iris and the peripheral angle. If it's associated with glaucoma, then it's called Rieger's syndrome. So here the cornea is decompensated. We're going to perform a host cornea trephination. I'm going to fast forward this part and just leave you with the IOL implantation. So a trephination, the donor trephination, going in, removing the cornea, and you can see there's a dense cataract. One of the issues here is that you can see the iris synechiae to the cornea, so it would have been impossible to place the lens in the anterior chamber in this case due to the iris synechiae. So strategically, it makes sense to put a posterior chamber intraocular lens, and we're doing here a intracap lens extraction, and then following an anterior vitrectomy. And then you can see here the Artisan lens enclaved open sky. Same technique. I'm right-handed, so I prefer to do the left hand enclavation first, and then grab the lens with my left hand, swift with the enclavation needle, the iris around the lens, guesstimate here. And you can see it's a little challenging because there's a lot of iris atrophy. And during the enclavation, I'm creating a few iris holes. But it has quite a leeway to allow you to enclave a significant amount of iris. And you can see on this snip, I was able to get a good grab of iris, snip it in the haptics, and I have good lens stability, and then finish off with penetrating graft, as you can see here, in a normal fashion. And this patient ended up doing pretty well. This is an Aphakia patient. Not many of those around anymore, so this is much more easy. Again, I'm preferring to go the scleral route here, a conjunctival pyritomy, a cornea sclera incision. I'm going here almost 2.5 millimeters posterior to the limbus, creating my scleral tunnel, and a little Michael here to attain meiosis. And again, same concept. This is our lens, IO power calculation with the A constant you saw before. We're using the 116.9, so almost 117. And since the lens has a slight curve, we flip the lens upside down so the curve does not rub on the iris. So the lens is basically hanging in upside down of what we would use it if we were placing it in the anterior chamber. So you can see the maneuver here. This is the lens as it is normally placed, and we will turn the lens. Sorry about that. So this is the lens, how it's normally set. You can see the curve of the lens, and we will turn the lens upside down and implant it upside down in order to avoid scuffing of the iris from the curvature side of the lens. So we place the concave side of the lens up, and the implantation is a similar fashion that you saw before. Very nice centration. This is probably the most difficult part. The learning curve is to estimate. You always want to, in the beginning, a lot of surgeons mark if let's say they enclave the lens here, they will mark the diametrically opposite side to guide them to enclave on the diametrically opposite side. Because if you enclave a little bit further outside that, then the lens will be displaced either superior or posteriorly. So in the initial steps, it does make sense once you achieve your first enclavation to just step back for a second, see what's the diametrical opposite side, put a marking here, and then use that as a guide. But after a few years of use, I've come to do this just empirically. And you see that the post-op centration is relatively good. Although there's still some correctopia, the lens is perfectly centered in the optical axis. And I think I have one or two more examples, and then I'll be happy to answer any questions. So again, this is a pediatric aphakic patient that had developed glaucoma, which we thought was from the vitreous coming into the anterior chamber. So our goal here was to treat this patient's glaucoma, but also place an intraocular lens to stop the communication of the vitreous cavity with the anterior chamber. So I'm using here triamcinolone to stain the vitreous and perform a thorough anterior vitrectomy. As you saw here, I'm checking to see if there's significant sommering ring of perhaps placing a three-piece IOL in the sulcus. There isn't. So I'm going to do an iridectomy, anterior vitrectomy, and here again, you'll see me flipping the lens upside down, changing hands, going in with my right hand initially, enclaving with my left hand the corresponding haptic. And at this point, now that you've enclaved this side, you can take a marker and mark the diametrical side to aid you on what exact point you need to target for. So again, lens enclaved, and then a tube shunt for this pediatric 11-year-old boy that was born with congenital cataract. And I'll show you some post-op pictures so we can see the lens is very well positioned. The valve is well positioned as well. And this is a endothelial graft patient that we'll see. The only novelty here is that we use the femtosecond laser to place the incisions. So a 5.5 millimeter incision for the Artisan lens. I'm taking the dislocated lens out. This was a lens that was placed with poor capsular support, and we assumed that the surgery was quite laborious, and that's why the patient developed pseudophakic bullous keratopathy. Due to the posterior chamber lens sunset and instability and the poor capsular support, I'm going to take this lens out, and I'm going to use again triamcinolone to stain the vitreous that's probably present, perform a thorough vitrectomy, and now we'll go on to the Artisan implantation part. And again, the power is calculated, keeping in mind that this lens will be placed behind the iris. So usually it has to be a stronger power lens than the one we will place in front of the iris. A rough rule is about a diopter and a half. Diopter and a half is a rough rule if you don't have time to make that calculation. So here I have a temporal incision. I'm going to place the lens through, reach the point, and here I tilt the lens. I tilt the lens a little bit to have the haptics protrude behind the iris and show me where my enclavation is going to be. So a generous enclavation. As you can see here, and then we'll switch hands, grab this lens from here and enclave the trailing haptic temporally. At this point, you can mark, if your enclavation is here, you can mark the diametrically opposite side to have a better centration of the lens. So gently place the lens in the posterior chamber and then come in and enclave the trailing haptic. And there's a few pearls on enclavation. If you want to enclave the lens here, you want to grab iris that's a little bit away from the point of inclination because there's a little bit of leeway that the grabbing of the iris gives you. So the lens will move a little bit towards the inclination side. So that's about 100, 200 micron of fudge factor you want to take into account during your inclination. Placing also a inferior iridotomy here with a vitrector to assure that there'll be no pupillary block because we're going to place air following the dissect graft. Sorry. I'll go back to this. And then just finish off with a dissect graft, the classic Busen spatula. And this is the patient post-op. The graft is cleared a lot, and you can see the nice centration, the diametrically opposite inclination points. A relatively good centration of the lens, a little bit of corktopia on the dissect graft. And again, this is far preferable in a endothelial transplantation procedure because you can see the posterior chamber implantation allows us to have a very deep chamber and thus a better outcome for our endothelial graft. So I'm very pleased with having the Artisan in my armamentarium because it gives me a lot of room to work either with glaucoma, as we saw before, or with endothelial grafts, especially if you're going to do DMEC. Now you can see this lens has really dropped. Again, a posterior intraocular lens that lost capsule support and has dropped through the capsule bag. And in similar fashion, take the lens out. Far more easier than start to suture that lens behind the iris, which is what I've seen some colleagues do. It's a brilliant technique, but it takes almost triple the time than just placing a lens which you have more precise biometry. If you suture a lens that was intended to be in the capsule bag on the iris, as you can imagine, you will get a shift, a myopic shift of probably 1 or 2 diopters. So again, same technique. It's almost using triamcinolone to make sure there's no vitreous in the anterior chamber, suture, and this is another result. Small iridectomy, very nice diametrical. Here, as you can see, I stretched the iris a little bit during the enclavation, and instead of re-enclaving the lens, I just did a little snip pupilloplasty to give a better pupillary aperture to the patient. It doesn't look great, but it's very functional for the patient. And this is, again, IOL exchange in an anterior chamber intraocular lens exchange, and again with a femto and astigmatic keratotomy, as you'll see here, due to the high astigmatism and an Artisan lens placement. So, in conclusion, I found that the Artisan is an extremely helpful tool in challenging anterior chamber cases, anterior segment cases, either combined with glaucoma procedures or cornea procedures. It is a much more easier procedure and steady in time in comparison to suturing a lens in the sclera or using the glue IOL technique or suturing the lens in the iris. And I think the only thing I blame myself of not thinking about this when I first started to work with a lens, when we used it in the anterior chamber, I think it's a far more easy, physiological, and matches well with other anterior segment procedures. Thanks very much for your attention.